Beginning. All right. So today's session, we are going to see about the GIT development. So it will be held up in two parts. Okay, part one and part two. Okay, foregut and midgut, we will be trying to finish it today. And the hindgut, we will complete it in the next session. All right. I hope you are able to see my screen. Yes? Okay. All right. So as discussed before, okay, in the foundation module, you must have learned that there is a trilaminar disc, ectoderm, mesoderm, and endoderm. Okay. The endoderm part is largely connected to the yolk sac. Okay. And initially, you know that the cardiac region is located more towards the anterior part. Okay. And there is an extension of the yolk sac, which is called as allantois. Okay. Later, because of the folding, what happens? This trilaminar disc is converted into a tube. Okay, it is converted into the gut tube. So here you can see the gut tube. Excuse me. So this one is the foregut, midgut, and the hindgut. Okay, and here you can see the blue colored part, which is the ectoderm. The red colored is the mesoderm and the endoderm. Okay, and because of the folding, the heart is now brought towards the ventral portion, and the gut, the foregut, goes towards the dorsal portion. All right, and the next part, the oropharyngeal membrane. Okay, the oropharyngeal membrane and the cloacal membrane. Okay, so here you can see the oropharyngeal membrane towards the foregut part. Okay, so here the ectoderm is coming in direct connection with the endoderm. Okay, so there is only very little amount of mesoderm. Okay, so this part later degenerates and then forms the future mouth. Okay, similarly on the hindgut, you can see once again the ectoderm coming in close contact with the endoderm. Okay, so which is called as the cloacal membrane, and this later degenerates to form the anal orifice. All right. Okay. Now the gut associated organs begins to form as buds from the endoderm. Okay, that is, there are certain structures which are arising from the gut. Okay, which are arising from the gut, especially the foregut. Okay, especially the foregut. Okay, so around the 22nd day, what happens is there will be certain gut associated organs, that is the structures which are developed from the GIT, they will form from the endoderm. Example, thyroid. Okay, so this we will be seeing in the development of the thyroid in the endocrine module. Okay, the lungs. Okay, the development of the lungs. This already we have dealt with in the respiratory module. You know that from the foregut there is a respiratory diverticulum which emerges. Okay, the liver and pancreas, which we will be seeing in today's session. Okay, so the gut associated organs, they form, they start to develop. Okay, especially from the foregut. The midgut opening to the yolk sac, progressively it narrows. Okay, you can see the midgut. Okay, the connection between the midgut and the yolk sac. Okay, initially you can see there is a huge gap. Okay, now this gap keeps on reducing it. Okay, it progressively narrows. All right. Then approximately by the end of the first month, okay, by the end of the first month, okay, so you will be able to see this is the foregut. Okay, consider this is the ectoderm, mesoderm. Okay, the ectoderm blue in color. Okay, and this is the mesoderm. So we are going to concentrate only on this part, the endoderm, okay, which is divided into foregut, midgut, and hindgut. Okay, so now here you can see the foregut, and in the foregut you can see the development of the thyroid. Okay, the development of the thyroid. the lung bud, and there is a small dilatation which forms the future stomach. Okay, which forms the future stomach. And at the end of the stomach, which is the duodenum, okay, there will be small buds which arises for the pancreas as well as for the liver, okay, as well as for the liver, okay, and the hindgut, okay. And here you can see the oropharyngeal membrane, okay, the oropharyngeal membrane, okay, and the midgut, okay, the midgut is connected to the yolk sac, okay, and is reduced. So this one is becoming progressively narrowed, okay. So that is the connection between the midgut and the yolk sac becomes progressively narrowed, and they form like a duct which is called as vitelline duct, okay, which is called as vitelline duct, okay. So this connection, they form what is called as vitelline duct, okay, vitelline duct. Okay, now with the lateral folding, the mesoderm is now taken into the gut wall, okay. Because of the folding, you can see initially, okay, so initially there is the midgut is opening into the yolk sac. Now because of the lateral foldings, okay, because of the lateral folding, the midgut is now formed like a tube, and there is only a small tube which is connecting them, which is the vitellointestinal duct, okay. And in the rest of the portion, if you see, it forms a complete tube, okay, it forms a complete tube. Now as it forms, okay, now as the lateral folding occurs, you note down here, okay, you note down the part here. There is a small connection, this yellow part, which is the endoderm, okay. There is a part which connects a part of the mesoderm which surrounds this endoderm and is also connecting towards the outer part, okay. So this is the visceral mesoderm and this is the parietal mesoderm, okay, the visceral mesoderm and parietal mesoderm. This is the one which later on transforms into peritoneum, okay. So this will become the visceral mesoderm will become the visceral peritoneum, and the parietal part will become the parietal mesoderm will become the parietal mesoderm, okay. Okay, the mesodermal layer of the gut tube, okay, the mesodermal is called as splanchnic, okay, or the visceral part, which is derived from the lateral plate mesoderm, and the somatic part, which is close towards the body cavity, okay, that is parietal and visceral. And here you can see there is a dorsal mesentery, okay, there is a dorsal mesentery. Okay, so to summarize, the structures which are developed from the foregut, midgut, and hindgut. From the foregut, all the structures from the pharynx until the proximal duodenum. Okay, proximal duodenum, you can say that until the second part of duodenum. Okay, so until the second part of duodenum, it is developed from the foregut. Okay, so pharynx, esophagus, stomach, and proximal duodenum. Now, there are certain other structures which are developed from the gut. So, these are the thyroid and parathyroid, the tympanic cavity, that is the middle ear, the trachea, bronchi, and lungs, liver, gallbladder, and pancreas. Okay, so now these thyroid and parathyroid we will see in the endocrine gland, the tympanic cavity of the middle ear. So, this we will be seeing in the neurological module. Trachea, bronchi, and lungs, we have already seen this in the respiratory module. So liver, gallbladder, and pancreas will be dealt in today's session. Okay, so these are the accessory GI structures which develop from the foregut. Now midgut, what are the structures which develop from the midgut? The remaining portion of the duodenum, okay, that is the distal duodenum. So here I mentioned it wrongly, it's the distal duodenum, okay. distal duodenum to the right half of the transverse colon. Okay, approximately the right half of the transverse colon. Some books say that right 2/3 of the transverse colon. Okay, so until this part, it is derived from the midgut. So that is the duodenum. What comes next to the duodenum? Jejunum, ileum. Okay, next to the ileum will be cecum, appendix, ascending colon, and the transverse colon. Okay, 2/3 of the transverse colon or the half of the right half of the transverse colon approximately. So all these structures are derived from the midgut. Now the hindgut, the remaining part of the GIT arises from the hindgut. That is the remaining 1/3 of the transverse colon. After the transverse colon, it is the descending colon, the sigmoid colon, okay, and then the anus. Okay, so these structures develop rectum and anus. So these structures develop from the hindgut. Okay, and apart from this, there is the urinary bladder also is a part of arises as a part of urinary arises as a part of hindgut. Okay, now how are these three regions defined? They are mainly defined by their blood supply. Okay, by their blood supply. So we will see that it here. The foregut is mainly supplied by an artery, which is the celiac artery. Okay, so here you can see the celiac artery. Okay, the celiac artery. The midgut is mainly supplied by the superior mesenteric artery. Okay, the superior mesenteric artery. And the hindgut is mainly supplied by the inferior mesenteric artery. Okay, so celiac artery, superior mesenteric artery, and inferior mesenteric arteries. All right. Now here, another point which you can note is there is, you can see that this is the aorta, dorsal aorta, and from this the celiac artery, superior mesenteric artery, and inferior mesenteric artery is arising. Okay, and there is a presence of dorsal mesentery. Okay, there is a presence of dorsal mesentery, which is extending from below the septum transversum. Okay, septum transversum, that is the developing diaphragm. So from the diaphragm until the hindgut, it is located, the dorsal mesentery, the orange colored part. Okay. Now, if you see, this is present along the entire part of the GI tract. Okay, from the foregut, midgut, and hindgut, the dorsal mesentery. Now, here you can see a small portion of the ventral mesoderm. Okay, a small portion of the ventral mesoderm here also. Okay, that is the ventral mesentery. But this ventral mesentery is present only in the foregut. The ventral mesentery is present only in the foregut. Okay, the ventral mesentery. So this is dorsal mesentery, and this one is ventral mesentery. This dorsal mesentery is given different names in different parts. Okay, so near the stomach, it is called as dorsal mesogastrium. Near the duodenum, it is called as dorsal mesoduodenum. Near the small intestines, it is called as mesentery, and here it is mesocolon. Okay, the dorsal mesentery is given different names in different portions. Okay, depending on the level at which the GIT it attached, which is attached to. Okay, so this one is a ventral mesentery. Okay, just remember this. In the next slide, we will see like what happens. Now let's see the esophagus. Okay, in the esophagus, this we have already seen in your during the development of the respiratory tract. Okay, there from the foregut there will be the formation of the respiratory diverticulum, and the respiratory diverticulum will form the trachea, bronchi. Okay, so the lung buds they will be arising from it. Okay, now these two are separated by the tracheoesophageal septum. Okay, the respiratory diverticulum is divided from the foregut by the tracheoesophageal septum. Okay, and if this tracheoesophageal septum is not separated completely, it leads on to tracheoesophageal fistula or the esophageal atresia. Okay, this we have seen in the development of the respiratory module. Okay, in the development of the respiratory tract, we have seen the 5 different types of tracheoesophageal fistulas, isn't it? So this is just the same, recapitulating the same thing. So because of the tracheoesophageal septum, the lung bud, the respiratory diverticulum gets separated from the rest of the pharynx. Okay, and if this is not divided completely, it leads on to tracheoesophageal fistula or atresia. Okay, and initially, if you see the esophagus, it is like a solid tube, but then later on, what happens? There will be vacuoles which are formed inside. Okay, and these vacuoles will join together, okay, to form a hollow tube. Okay, to form a hollow tube. Okay, so initially the esophagus, okay, the endodermal lining, okay, so it proliferates and the lumen is obliterated. Okay, but later on what happens, because of the recanalization by these vacuoles, okay, so the canalization is established. The esophagus becomes a hollow tube. Okay, if there is any error in this vacuole formation or in this union of these vacuoles, it can lead on to the esophageal stenosis. Okay, esophageal stenosis. Okay, this is the same mechanism by which the stenosis occurs in other parts of the GIT as well. Okay, for example, the duodenal stenosis. Okay, the duodenal stenosis. Now, the esophageal tube is initially short, and as the fetus grows, okay, as the fetus grows, the foregut should also increase in length. Okay, it should also increase in length. If this increase in length of the foregut does not occur, okay, if this increase in foregut, the length of the foregut, if it does not occur, it leads on to congenital hiatal hernia. Okay, this you already know this, right? You must have heard it in the pathology. So what happened, hiatal hernia? So a small portion of the stomach is coming into the thorax, okay, through the hiatus. It's called as hiatus hernia. Okay, so the stomach is pulled into the thorax, okay, through the opening, okay, through the esophageal opening. Okay, so now you will know like why it occurs. Okay, the congenital hiatal hernia occurs because the growth of the esophagus is not keeping up with the growth of the fetus. Okay, so when the fetus grows, the foregut also should grow. Okay, if it doesn't grow, it can lead on to congenital hiatal hernia. All right, so that's about the development of the esophagus. Now let's see the development of the stomach. Okay, the development of the stomach. Okay, so initially you have seen that there is a fusiform dilatation near the end of the just in the above the end of the foregut. Okay, fusiform dilatation. Okay, so that is the developing stomach. And what happens, this stomach, it undergoes a rotation. Okay, it undergoes a rotation. How many degree rotation? It undergoes a 90-degree rotation. Okay, a 90-degree rotation. So in such a way that the left side moves ventrally and the right side moves dorsally. Okay, or the left side moves anteriorly. Okay, and the right side moves dorsally. So this is clockwise or anti-clockwise? It is in the clockwise direction, isn't it? Okay, so it rotates 90-degree clockwise. Okay, it rotates 90-degree clockwise in such a way that the left side, okay, the left side of the stomach becomes the anterior and the right side becomes the posterior. Okay. Now, if you see in the tracheoesophageal septum, there will be vagus nerves, right? So there will be vagus nerve near the tracheoesophageal septum. Okay, so there will be recurrent laryngeal nerve. Okay, which emerges from the vagus nerve, which is passing on either side of the pharynx. So initially in the pharynx level, you can see there are right and left vagus nerves. But what happens when it comes to the stomach? We call it as anterior vagus and posterior vagus. Okay. So during the surgery, they will tell us anterior vagal truncotomy. Okay. So they will say like we will cut the anterior vagus or the cut the posterior vagus for gastric ulcers. Okay. Vagotomy. Okay. So that you know that, isn't it? So now how come this vagus, which is on the right and left, becomes anterior and posterior? It is because of the rotation of the stomach. So initially there will be right and the left vagus. Now because of the rotation, the left side comes to the anterior. Okay, so the left vagus becomes anterior vagus and the right vagus becomes posterior vagus. Okay, so this is the first change which occurs in the stomach. The second change, after the rotation, what happens is there will be the establishment of the greater and the lesser curvatures. Okay, there will be the establishment of greater and lesser. Once after the rotation, what happens? The now the left side part will not grow. Sorry, the left side part will grow at a much higher pace than the right margin. Okay, the right margin. Okay, the left margin will grow at a much higher pace compared to the right margin. And because of this, it forms the lesser curvature and the greater curvature. Okay, the lesser curvature and the greater curvature. Okay, so now here you can see the right margin is not growing at a much higher pace compared to the left margin. Okay, so now the left margin grows at a much higher pace. Okay, and that's why there is the formation of the greater curvature. Okay, and then the lesser curvature. Now already you know that there is a mesentery. There is a mesentery. Okay, a ventral mesentery and a dorsal mesentery. Okay, so in this place you can see the stomach. Okay, there is a ventral mesentery and a dorsal mesentery. Okay, so this ventral mesentery will form the lesser omentum and the dorsal mesentery will form the greater omentum. Okay, it will form the greater omentum. Okay, the caudal end of the stomach is separated from the duodenum by the formation of pyloric sphincter. Okay, pyloric sphincter, just like in esophageal stenosis. So what happens in the esophageal stenosis? Initially there is the all the endoderm, it is present. Okay, and it is obliterated, then the vacuoles come and then they make the hollow tube, isn't it? So similarly the stomach is also like that. Okay, then later on the vacuoles join and then make it like a tube. Okay, and near the pyloric end there will be little formation. Okay, and the muscles, the mesoderm, the endoderm are muscles which are around this. Okay, so they will form the pyloric sphincter. Okay, they will form the pyloric sphincter, and if there is the vacuolization does not take place properly, it leads on to pyloric stenosis. Okay, it leads on to pyloric stenosis. Okay, so here you can see the pyloric stenosis. Okay, the pylorus part. Okay, congenital hypertrophic pyloric stenosis. Okay, so what is the characteristic? Because the pylorus is hypertrophied, and as a result, what will the person have? Projectile vomiting. Okay, projectile vomiting. Okay, so there will be projectile vomiting means the vomit will comes out with such a force. Okay, sometimes even without the person realizing that he is going to vomit. Normally, when a person vomits, he rushes to the washroom or to a safe place to let the vomiters. But in projectile vomiting, even without nausea, it just comes out, okay, with such a force. Okay. And this pyloric sphincter can also be palpated, okay, as a spherical nodule in the epigastric region, okay, in the epigastric region of the abdomen. Okay, and this stenosis is due to overproliferation, okay, and hypertrophy of the pyloric sphincter. It is not because of recanalization. Okay, it is not because of error in recanalization. It is because of the hypertrophy of the sphincter. Okay, the reason is not known, but this is more common in males compared to females. Okay, so it is more common in male children. Okay, so in the male child, this is more common. Okay, so you can see here, what do you call this one as? Visible gastric peristalsis. Okay, visible means you can see it even with the naked eye. Gastric stomach peristalsis. You can see the movement of the stomach going from the left towards the right side. Okay, visible gastric peristalsis. Okay, and if you see the vomiters does not contain any bile. It's a non-bilious vomiting. Okay, if it is a bilious, is what color? What color? It's green in color, isn't it? So if it is a bilious vomiting, you can suspect duodenal stenosis. Okay, duodenal stenosis. But usually in hypertrophic stenosis, okay, it will be just vomiting. Okay, and they can also go in for electrolyte imbalance. Okay, electrolyte imbalance. Why? Because stomach, as you know, that it has got acid, right? It secretes acid, HCl. So because of the vomit, hypertrophic pyloric stenosis, if the child keeps on vomiting, what happens? The acid is let out and the child can go in for alkalosis. Okay, it can go in for alkalosis. Okay, hypochloremic alkalosis. So the chlorine content will be very less. Okay, when you check the blood serum electrolytes of these patients, so the chlorine content will be very less. Okay, so hypochloremic alkalosis. All right. So that's regarding the development of the stomach. Do you have any doubts until now? Do you have any doubts?
Sure, can you repeat the pyloric sphincter?
The pyloric sphincter. So initially the pyloric sphincter. Okay, so the pyloric sphincter is just formed by recanalization. But this hypertrophic pyloric stenosis is not because of the error in recanalization. Okay, it is because of the hypertrophy of the muscles which are present around the pyloric part. All right.
What do you mean by recanalization?
Recanalization, I told you, in the esophagus. This is called as recanalization. So initially the esophagus is like a tube, okay, solid tube. What happens later is the vacuoles. So these vacuoles, they will join and recanalize. Okay, so they will make the tube open, okay, hollow tube. Okay, so that's called as recanalization. Okay.
A
Thank
doctor,
Yes,
how is the lesser and the greater omentum formed again?
I'll come to it again. Okay, I'm coming to this part, coming to that part now. Until now,
Thank you.
yeah. Until now, do you have
No,
any
thank
other
you, doctor.
questions? Yes. Okay. Now, so we are now going to take a closer look into the mesenteries. Okay. So you can see that the foregut, midgut, and the hindgut. Okay. Now, only the foregut has got both the dorsal mesentery and a ventral mesentery. whereas the rest of the part has got only the dorsal mesentery. Okay. Okay, so the dorsal, so the ventral mesentery is present only in the foregut, that is below the diaphragm. Okay, that is below the diaphragm. Okay, so this mesentery, okay, so this mesentery, okay, the ventral mesentery, it is going and getting attached to the septum transversum. It is going and getting attached to the septum transversum, which later on gets modified into diaphragm. Okay, into diaphragm. Also, there will be a thickening which forms in the septum transversum, which forms the liver. Okay, which leads on to the formation of the liver. Okay, now the part between the stomach and the liver, this is called as the lesser omentum. Okay, this is called as the lesser omentum. Now there will be some part of the ventral mesentery from the liver to the anterior abdominal wall. Okay, from the liver to the anterior abdominal wall, and that is called as the falciform ligament. Okay, that is called as the falciform ligament. Okay, so the part between the stomach and the liver, so that the ventral mesentery, that forms the lesser omentum. The part of the ventral mesentery between liver, okay, and the anterior abdominal wall, that forms the falciform ligament. Okay, falciform ligament. Okay, I don't think liver is finished for you, right? Cross anatomy of liver is over.
No, sir.
Yes, that is why we are unable to understand, because the liver, if you see, it is covered by a large amount of peritoneum. Okay, the liver is covered by the peritoneum, and these peritoneum coverings, they will form a few ligaments. Okay, like a triangular ligament, falciform ligament, okay, coronary ligament, like that it will form the thickening of the peritoneum, which covers the liver. You know that liver is the largest gland. Okay, so this is one of the ligaments, that is the falciform ligament. It extends from the umbilicus to the anterior part of the liver. Why it is called falciform? Falx means sickle shape. Okay, because it is looking like a sickle. Okay, this is called as falciform ligament. Okay, the falciform ligament. So the ventral mesentery, okay, is modified from the stomach to the liver as lesser omentum, and from the liver to the anterior abdominal wall as falciform ligament. Now, what happens to the dorsal mesentery? Okay, the dorsal mesentery, especially in the stomach region, it will form the greater omentum. Okay, it will form the greater omentum. Now, near the small intestines, the dorsal mesentery, because it is connected to the small intestine, it is called as mesentery. Okay, and after the small intestine comes the large intestine. Okay, so in the large intestine, this mesentery, the dorsal mesentery, is referred to as dorsal mesocolon. Okay, dorsal mesocolon. Okay, so now here you can see this is the lesser omentum and this is the greater omentum. Okay, this is the lesser omentum and the greater omentum. Okay, all right.
So
Now,
the
yes,
mesentery is a muscle, or
mesentery is not a muscle. Mesentery is it is like, wait, I'll just show you the picture. See, this is the mesentery. See, initially the gastrointestinal tract, the endoderm, okay, so the which is forming the gut tube, okay, it is present along with the body wall. Okay, but there will be an extension from the body wall through which the blood vessel comes out. Okay, which is a part of the mesoderm. Okay, it is a part of the mesoderm through which the blood vessels will come. So this is the dorsal mesentery. Okay, if this dorsal mesentery is absent, it is called that these organs are retroperitoneal. Okay, the retroperitoneum means that the dorsal mesentery is not present. Okay, when the dorsal mesentery is not present, it means that they are retroperitoneal. All right. Okay, now what I'll do is I will just show you a video. So this is from the YouTube. Okay, so regarding the development of the stomach. Okay, so this is from the same person, the Ackland. Okay, and he is giving out the development of the stomach.
As it develops, it rotates on its long axis, lengthens in a downward curve, and expands to become the stomach and the first part of the duodenum. The foregut is different from the rest of the GI tract. The hindgut and midgut are attached to the body wall by a double-folded peritoneum, only along the back. The foregut is attached also at the front.
So now do you see? Compared to the foregut and compared to the midgut and hindgut, okay, the midgut and hindgut is attached only to the posterior side. So which is the dorsal mesentery. Okay, dorsal mesentery. But the foregut is different.
Only along the back. Foregut is attached also at the front.
The foregut is also attached into the front. Okay, the foregut is also attached in the front. Okay, and this part, just a second. Okay, so since the main part which arises from the foregut is the stomach, this part is called as dorsal mesogastrium. Okay, and this part is called as ventral mesogastrium. Okay, because this is the developing stomach. Okay, so this is the developing stomach. Okay, so this is dorsal mesogastrium. This is ventral mesogastrium. Okay, now let's see what happens.
Mesogastrium in front. As the foregut.
Now what happens? The stomach will rotate 90 degrees. Okay, so it rotates 90-degree clockwise directions. Okay, now what happens when it rotates 90-degree clockwise?
Dorsal and ventral mesogastrium rotate with it.
So what happens when the stomach is rotating? The dorsal mesogastrium and the ventral mesogastrium is also rotating. Okay, so you can see the dorsal mesogastrium. This is the dorsal mesogastrium, and the ventral mesogastrium is also rotating, isn't it? Okay, now let's see.
The line of attachment of the ventral mesogastrium swings round to the right as the foregut develops.
So initially, which was the mesogastrium, which was in the anterior part, the ventral mesogastrium, now it goes towards the right side. Okay, and you know there is a development of the liver here, and the attachment of the ventral mesogastrium to the liver, which is called as lesser omentum.
It ends up running along the lesser curve of the stomach and the top of the proximal duodenum. On the back, the attachment of the dorsal mesogastrium swings round to the left. It ends up running along the greater curve of the stomach and the underside of the proximal duodenum. While the foregut is developing, there are important changes in the ventral and dorsal mesogastrium. The liver develops in the ventral mesogastrium.
Okay, so now you see what happens in the ventral mesogastrium. In the ventral mesogastrium, there is the development of the liver. Okay, there is a development of the liver. Okay, now that is ventral mesogastrium is nothing but ventral mesentery. Okay, ventral mesentery. Because it is present in the stomach region, we are call it as ventral mesogastrium. Okay, so now in the ventral mesentery, what happens? There is the development of the liver. Now this part from the stomach to the liver, this is referred to as the lesser omentum. Okay, and this part from the liver to the anterior abdominal wall. This is called as falciform ligament. Okay, this is called as falciform ligament.
The spleen develops in the dorsal mesogastrium.
Okay, so now what happens? From the dorsal mesogastrium, the spleen develops. Okay, the spleen develops. So there is a line, there is a part of the mesentery which attaches the stomach to the spleen, gastrosplenic ligament. Okay, gastrosplenic ligament. Okay, and from the spleen to the posterior abdominal wall. Okay, to the posterior abdominal wall. So in the posterior abdominal wall, there will be the development of the kidneys, and that will form the leno-renal ligament. Okay, leno-renal. Leno is another name for spleen. Okay, leno-renal ligament. So gastrosplenic ligament and leno-renal ligament. Okay, now from the ventral mesentery, liver develops. From the dorsal mesentery, spleen develops.
In the dorsal mesogastrium, the liver grows rapidly, pressing against.
So now what happens? The liver is growing at a rapid rate. Okay, it is growing at a rapid rate.
The body wall and obliterating these layers of peritoneum.
Okay, so and it will obliterate the posterior part. Okay, now here if you see, this is called, what is this one? This is the greater sac, and this one is the lesser sac. Okay, this is lesser omentum, the greater omentum. Okay, this part is the greater sac, and this part is the lesser sac, also called as omental bursa. I will repeat the video again at the end.
These changes produce this almost separate pocket behind the stomach, the lesser sac. This part of the ventral mesogastrium is the lesser omentum. This part of the dorsal mesogastrium will become the greater omentum. We'll follow these changes from the start in a more three-dimensional way.
Okay, so once again we will see this video. Okay, from this part.
On its long axis, lengthens in a double curve and expands to become the stomach and the first part of the duodenum. The foregut is different from the rest of the GI tract. The hindgut and midgut are attached to the body wall by a double fold of peritoneum, only along the back. The foregut is attached also at the front. Its two attachments are the dorsal mesogastrium behind and the ventral mesogastrium in front. As the foregut rotates, the dorsal and ventral mesogastrium rotate with it. The line of attachment of the ventral mesogastrium swings round to the right as the foregut develops. It ends up running along the lesser curve of the stomach and the top of the proximal duodenum. On the back, the attachment of the dorsal mesogastrium swings round to the left. It ends up running along the greater curve of the stomach and the underside of the proximal duodenum. While the foregut is developing, there are important changes in the ventral and dorsal mesogastrium. The liver develops in the ventral mesogastrium. The spleen develops in the dorsal mesogastrium. The liver grows rapidly, pressing against the body wall and obliterating these layers of peritoneum. These changes produce this almost separate pocket behind the stomach, the lesser sac. This part of the ventral mesogastrium is the lesser omentum. This part of the dorsal mesogastrium will become the greater omentum.
Okay. Any doubts? Okay, so now I'll just show you this picture again. Can you see these two pictures? These two pictures? This is the same one which was shown in the video. So here you can see the stomach, the ventral mesentery, and in the ventral mesentery or the ventral mesogastrium, there is a developing liver. Okay, so this liver enlarges. So this forms the lesser omentum, and this will be the falciform ligament. Now, in the dorsal part, the dorsal mesogastrium or the dorsal mesentery, there will be the development of the spleen. Okay, there will be the development of the spleen. Okay, and this part will become the greater omentum. Okay, this part will become the greater omentum. Okay, and that will become the lenorenal ligament. Okay, it will become the lenorenal ligament. Okay, lenorenal ligament. Okay, they can see the developing kidneys here. Okay, the kidneys, the pancreas. Okay, also note that the pancreas is also present in the initially the pancreas. It is an intraperitoneal structure, but later on the pancreas becomes a retroperitoneal structure. We will see about this later. Okay, and there is initially you can see there are only two parts. Okay, but because of the rotation of the stomach, the lesser sac is formed. Okay, the lesser sac is formed. All right.
Doctor, can you see the gastrosplenic ligament?
Gastrosplenic ligament. Okay, in this picture I cannot show you because it is just a small thickening in the greater omentum. Okay, in the greater omentum, so there will be a small thickening which extends from the stomach to the spleen. Okay, and that's called as gastrosplenic ligament. All right. Okay,
Doctor?
now let's. Yes.
So basically, the doctor.
Yes. Yes, sir.
So basically, the lesser omentum and the greater omentum is mesentery, but does it, but in the intestine it's called mesentery, but in the stomach it's just called lesser and greater omentum.
Yes. Yes.
And it's a serous membrane, right?
Yes.
Filled with fat.
Yes.
Okay. Thank you, doctor.
All right. Now we have seen one view. So this is the cross-sectional view. Okay.
Follow these changes from the start.
So this is a cross-sectional view. We have seen like how the ventral mesogastrium and the dorsal mesogastrium they develop. Now the same thing we are going to see in a different view.
To do that, we'll go from below. Here we're looking up into the upper part of the abdominal cavity. This is the diaphragm. Here's the foregut starting to develop. Here's the liver developing in the ventral mesogastrium and the spleen developing in the dorsal mesogastrium. Here's the space that will be the lesser sac. This is the lesser omentum. This part of the dorsal mesogastrium will grow downwards to become the greater omentum. We'll move to a slightly lower vantage point so we can add the duodenum to the picture. The foregut ends here. So does the lesser omentum.
Okay, the foregut ends in this part. Okay, so the ventral mesentery also ends in this portion. And that is why here you can see a small opening, right? Which is called as the epiploic foramen or foramen of Winslow, which is the opening which leads to the lesser sac. Okay, the lesser sac, which is also called as a omental bursa. So this pocket at the end of the lesser omentum, okay, at the end of the lesser omentum, that is the lesser omentum end, okay, in the proximal part of the duodenum. After the pylorus, the duodenum, okay, so this part will end, okay. The foregut ends here, okay, and this part, the ventral mesentery also ends here, and this part which connects them is the epiploic foramen.
This is the lower free border of the lesser omentum. Below it, the duodenum becomes stuck against the liver, leaving this opening, the epiploic foramen that leads into the lesser sac. The dorsal mesogastrium is shown as though it had a free lower border along here, but in reality, this fold is continued all the way round to here, creating a sac that has only one opening, here. To see how the greater omentum develops, we'll
So
first
here,
add the transverse colon to the picture. The dorsal mesogastrium hangs down in front of the transverse colon. To follow its growth, we look at a sagittal section made in this slide.
So initially, if you see, the dorsal mesogastrium is extending down, which forms the greater omentum. Okay. Now let us see like what are the changes which takes place here in this diagram. Okay. So this is what do you call it as? Which section is this? It's a sagittal section. Okay, parasagittal section. Okay. So what happens in this parasagittal section? So here you can see the liver, the stomach. Okay. So there is the part of the ventral mesentery which extends into the liver. Okay. This is the lesser omentum. Okay. This is the stomach. This is the greater omentum. Okay. The dorsal mesentery, and here it is called as greater omentum. The greater omentum is going back to the posterior abdominal wall. This is the pancreas. Okay. And this is the mesocolon. This is the transverse colon. Okay. This is the transverse colon. Okay. So here in this picture, you can see they have put the transverse colon, right? So if you take a parasagittal section, so these are the things which you come across. Okay. So these are the things which you come across. The lesser omentum, stomach, greater omentum, pancreas, colon, transverse colon. Okay. And this part of the dorsal mesentery, this is called as mesocolon, transverse mesocolon. Okay. Transverse mesocolon. Now let us see.
Omentum between the liver and the stomach. Here's the greater omentum, hanging down in a double fold. Below it is the transverse colon, suspended by the transverse mesocolon. This is the pancreas. The greater omentum grows downwards in front of the transverse colon. The greater
So now you can see the greater omentum, which is also called as the policeman of the abdomen, right? So the greater omentum is called as the policeman of the abdomen. Okay. It extends down. Okay. It extends down. And
the transverse mesocolon come together. And the duplicated.
Can you see here what happens? This part of the greater omentum, okay, gets attached with the transverse colon, transverse mesocolon, and they form one single structure. Okay, so
layers are absorbed, so that we're left with the greater omentum stuck to the transverse colon and hanging down below it.
so when you see in the dissected specimen, what do you see? When you open up the stomach, you will be seeing the greater sac. Okay, and this one is the lesser sac. From the stomach, there will be greater omentum which is hanging down. Okay, the greater omentum which is hanging down. Okay, now these two layers. Okay, actually there are two layers. If you see here, 1, 2, 3, 4. Okay, so there are 4 layers. Okay, and this space, okay, this space of the lesser sac, it gets obliterated, and this part, it also gets fused with the transverse colon. Okay.
The greater omentum and the transverse mesocolon come together, and the duplicated layers are absorbed, so that we're left with the greater omentum stuck to the transverse colon and hanging down below it. The lesser sac lies behind the lesser omentum, the stomach, and this part of the greater omentum, the gastrocolic ligament. The duodenum lies.
All right, now you got it. So now this is the
Doctor.
location. This is the location of the lesser sac. Okay, the location of the lesser sac, which is behind the lesser omentum, which is behind the stomach, which is behind the stomach. Okay, and behind the, just a moment, which is behind the stomach. Okay, behind the lesser omentum, behind the greater omentum. Okay, and above the colon. Okay, so this part is the lesser sac. Okay, this part is called the lesser sac. Okay, now why this is important? Okay, in a developing child, say for example, in a developing kid, during the development, okay, if you do an autopsy of the kid, you will be able to see the stomach and you will be able to see the greater omentum. If you lift the greater omentum, you can go above the transverse mesocolon. Okay, you can go above the transverse mesocolon. Okay, but what happens as the child grows, it gets fused. Okay, so now what happens if you lift this greater colon, it will be like a curtain. That's all. It will be just like a curtain hanging down from the stomach. And if you lift this greater omentum, you will be able to see the transverse colon. Okay, and if you lift this transverse colon, you will be able to see the bottom portion of the transverse mesocolon. Okay, you will not be able to see the upper part of the mesocolon. Okay, the upper part of the mesocolon, because it is now fused and it becomes a part of the lesser sac. Okay, it becomes a part of the lesser sac. All right. I suggest you to watch through this video again and again so that you can understand like how is the lesser sac formed. Yes, do you have any doubts?
Doctor?
Yeah.
Lies behind the lesser omentum.
Yes.
The transverse colon is the same as transverse mesocolon is the same as dorsal mesocolon.
Yes. Yes. All are developed from dorsal mesentery. Okay. In each part, it is given different name. Okay, the dorsal mesentery in the stomach, it is called as dorsal mesogastria. Okay,
Okay.
the
Okay, thank you.
dorsal mesentery in the colon, it is called as dorsal mesocolon.
Okay, got it. Thank you, doctor.
Yes,
Doctor,
yes.
what is pushing the greater momentum to go and fuse with the transverse mesocolon? Like, what is pushing it down?
It's not pushing. As it grows, it gets absorbed.
So it's just going down by itself?
Yes, it's going down by itself
Okay.
because of the growth. Because of the growth of the other abdominal organs.
All right.
All right.
Fine. Yeah.
Okay.
The stomach and in the embryo. Also development. It got forms of food.
Okay.
Twists come.
So this is the next part. Okay, so we'll come back to our PowerPoint. So now you know how the lesser sac is formed, how the falciform ligament is formed, okay, and how the lienorenal ligament is formed. Okay, all right.
Sir, can you repeat the lesser sac part again?
Which part?
The lesser sac part only.
Lesser sac. Just now I had it maybe again. Why don't you watch this video again? I'll be sending you the link as well. Okay, you send this video.
This fold.
Okay, and if you still have doubts, I will repeat you in the wrap-up sessions. Okay, I'll just show you the video again. Yeah. Okay, so initially you can see okay, so this is dorsal mesentery, the dorsal mesentery and ventral mesentery, liver developing from the ventral mesentery and spleen developing from the dorsal mesentery, and this part is the lesser sac. Okay, this is the lesser sac. Okay, the sagittal in the cross section, in the transverse section. In the sagittal section, okay, in the sagittal section, this is the lesser sac and this is the greater sac. All right. Now this I gave you because of the union between greater omentum, and the dorsal mesentery and the mesocolon. Okay, the dorsal mesentery and the colon, and this is the lesser sac. All right.
Sir, the white thing is the kidney?
No, white kidney is the pancreas. This one is the
Yes.
pancreas. It's the pancreas. This is the stomach, liver, transverse colon. All right. I can understand it is a bit difficult to understand. Okay, but you need to go through it again and again. Okay, I'll be sending you the recorded version. Okay, so please go through it again and again. Okay. All right. Now, I thought I'll complete until mid-gut. Okay, I don't think we will have time until mid-gut. We'll finish only the foregut today. Now, what happens after the stomach? Okay, after the stomach, you know, there is duodenum, right? There is duodenum. Now, what are the changes which takes place in the duodenum? Okay, you know that the gland, liver gland develops from the septum transversum. Okay, but the duct, the duct of this gland, that is the common hepatic duct. Okay, for you, the liver is not finished, right? Okay, so I need to describe you the normal ones. The normal ones. Okay, the normal one where from the duct, from the liver, there will be hepatic duct. Okay, this hepatic duct joins with the dorsal pancreatic duct. Okay, let me try to find out something from the lecture. Yes, this is actually the pharmacy lecture because you have not finished the liver and GIT. I am just teaching you this one. Okay, see, this is the liver. From the liver, there is hepatic duct. Okay, hepatic duct. The right and left hepatic duct, they join together to form common hepatic duct. Okay, the common hepatic duct. Okay, from the common hepatic duct, okay, this joins with the cystic duct. The cystic duct is coming from the gallbladder. Okay, the cystic duct joins with the common hepatic duct to form common bile duct. Okay, the common bile duct then joins with the pancreatic duct and opens into the second part of duodenum. This you know, the duodenal papilla. Okay, the duodenal papilla. Okay, so the hepatic duct, right and left hepatic ducts join together to form the common hepatic duct. The common hepatic duct joins with cystic duct, which comes from the gallbladder. Okay, and then they form the common bile duct. Okay, the common bile duct joins with the pancreatic duct and opens into the second part of the duodenum. All right, this will be taught to you in your liver lecture. Okay, in the lecture gross anatomy of the liver. Okay, now we are going to see how this is developed. How the liver and the pancreas, the cystic duct, the common bile duct, and the hepatic ducts are derived. Okay, so now what happens? Do you see from the stomach, the liver and pancreas are arising from the end part near the distal end of the foregut. Okay, near the distal end of the foregut. Okay, so there will be a part of the pancreas which arises on the dorsal side, dorsal or the posterior side, which is called as the dorsal pancreatic bud. There will be another bud which arises on the ventral aspect, and that is called as ventral pancreatic bud. Okay, ventral pancreatic bud. Okay, now what happens after this? The ventral pancreatic bud also extends, it extends towards the liver. Okay, towards the diaphragm, forming the liver. Okay, as it extends, there will be a dilatation which forms the gallbladder. Okay, which forms the gallbladder. Okay, then later on there will be a constriction from this gallbladder which forms the cystic duct. Okay, and this duct which goes and joins with the liver, okay, that forms the hepatic duct, the common hepatic duct. Okay, so now this common hepatic duct joins with the cystic duct to form the common bile duct. Okay, and this common bile duct mixes with the pancreatic ducts, and they open into the second part of duodenum. Now if you see, there are two pancreas, dorsal pancreas and ventral pancreas. Okay, embryologically there are two pancreas. Now how come this two pancreas changes into one pancreas? Okay, so now here you see. Okay, so here you can see the dorsal pancreas, the ventral pancreas. Okay, and here you can see the common bile duct, cystic duct, gallbladder, common hepatic duct, and the hepatic ductules which goes into the liver. Okay, which goes into the liver. Okay, now there is a rotation of the duodenum. Okay, because the stomach rotates, a small portion of this duodenum also rotates. Okay, the rotation of the duodenum, this brings the ventral part, the ventral pancreatic bud, okay, to the dorsal part. Okay, the ventral pancreatic bud towards the dorsal part, towards the dorsal pancreatic bud. Okay, now because of the rotation, dorsal means initially it is located on the posterior side. Okay, because of this 90-degree rotation, the pancreas which is on the posterior side, it will be now extending towards the left side. Okay, and the ventral pancreatic bud, it will take a turn. Okay, it will take a huge turn. Okay, and it will get connected towards the dorsal pancreatic bud. Okay, so once again I'm telling you, because of the rotation of the duodenum, okay, because of the rotation of the duodenum, okay, which is also partly supported by the stomach, the rotation of the stomach, the dorsal pancreatic bud, okay, moves towards the left side. The dorsal pancreatic bud moves towards the left side. Okay, now the ventral pancreatic bud, it also rotates. It takes a huge turn, and as it turns, as the ventral pancreatic bud turns, it also brings the common bile duct along with it. It also comes along with the common bile duct. Okay, all right. Now another thing which you need to observe, if you see, there is the dorsal pancreatic bud has got an opening. Okay, the dorsal pancreatic duct secretions, they will open into the duodenum. Now the ventral pancreatic duct and the common bile duct, they also open into the duodenum. So there are two openings. You must have already read this in your gross anatomy of the duodenum, right? Major duodenal papilla and minor duodenal papilla. Okay, which is above and which is below? Any idea?
Minor is above.
Very good. Okay, the minor pancreatic duct is above and the major pancreatic duct is below. But here if you see the pancreas, the dorsal pancreatic bud is huge. Okay, and this opening should be the major one, right? How come this becomes the major one? So initially, if you see the two pancreatic buds, okay, the two pancreatic ducts, they are present. Okay, the dorsal pancreas, they have a duct. The dorsal pancreas, they have a duct. The ventral pancreas, they have a duct. Okay, the ventral pancreas, they have a duct. Okay, along which joins with the common bile duct. Now, in this picture, okay, it is shown very minutely. What happens is, from the dorsal pancreas, the pancreatic duct, there is a connection to the ventral pancreatic duct along this line. Okay, can you see after the fusion takes place between the dorsal and ventral pancreas, there is a connection between the ducts also. So major portion of the dorsal pancreas, okay, the major portion of the dorsal pancreatic bud secretions also comes to the ventral pancreatic duct, and then they open into the major papilla. The small portion of the pancreas, okay, which is the head of the pancreas, the small portion of the head of the pancreas, they will have another opening, which is the minor duodenal papilla. Okay, they will have another opening, which is the minor duodenal papilla. Okay, so basically for all the cross anatomical features, you need to know like how this is embryologically formed. Okay, so initially you can see the ventral pancreatic bud has got a separate opening and dorsal pancreatic duct has got a separate opening. But later on, after the fusion, okay, due to the rotation, okay, the ventral pancreatic bud becomes the lower part, okay, and the dorsal pancreatic bud. Okay, and what happens? The dorsal pancreatic duct secretions, they get towards the ventral pancreatic duct. Okay, and this ventral pancreatic duct joins with the common bile duct, okay, and then they open into the major papilla. Whereas in the minor papilla, it will be pure pancreatic secretions. Okay, the minor papilla will have pure minor pancreatic secretions, that too only a small portion of the pancreas, because the major secretion from even from the dorsal pancreas is coming through this connection between the dorsal pancreatic bud duct and the ventral pancreatic duct. Okay, did you understand this one? All right. Another abnormality, the annular pancreas. Annular pancreas. Okay, the annular pancreas. So here I said like the ventral pancreas takes a turn and then gets attached to the dorsal pancreas. Okay, during this turn, if there is any abnormality, okay, or if it rotates, if the ventral pancreas rotates in an opposite direction, it appears that it is squeezing the duodenum. It is all around the duodenum. Okay, it is all around. The pancreas is surrounding the entire duodenum. So there is a functional duodenal stenosis. Okay, there is a functional duodenal stenosis. So that is actually the duodenum is not stenosed. Okay, but there is an external compression of the duodenum because of the pancreas. Okay, because of the pancreas. So this is called as annular pancreas. They will also have similar symptoms like duodenal stenosis. So what are the symptoms for duodenal stenosis? Once again, projectile vomiting, but the projectile vomiting will contain bile. Okay, bile, which comes from the gallbladder and the common bile duct. Okay, so in duodenal stenosis, there will be bile. Okay, so even in annular stenosis, there could be bile. Okay, so because the obstruction is present in the duodenum. All right, any doubts? Now here in this, once again, I'm showing you the dorsal pancreatic bud. Okay, so the pancreas initially, which is present here along the dorsal mesentery. Now, because of the rotation of the stomach as well as the duodenum, the pancreas now comes towards the left side.
So I have a question.
Yes.
The pancreas moved to the left side. How did it connect with the common bile duct?
Here, can you see the ventral pancreatic duct? This is the ventral pancreatic duct, right? The ventral pancreatic bud and the ventral pancreatic duct. Now, as the ventral pancreas rotates, what happens to the common bile duct? The common bile duct is also brought down. Can you see here?
Oh yeah, I saw it. I didn't see it.
Okay.
I didn't see it.
All right.
Excuse me, doctor.
Okay, so yes.
In the rotation, of the pancreas, is it just the ventral pancreas which rotate?
The
And
dorsal
the dorsal
pancreas also the dorsal pancreas also rotates. See here, the dorsal pancreas is initially on the posterior side, isn't it? Because of the rotation, the dorsal pancreas is turning to 90 degrees. Okay, initially it is vertical. Okay, so now it is rotated to almost 90 degrees. Okay, but the ventral pancreas takes a huge turn. Okay, the ventral pancreas take huge turn, almost like 180, not exactly 180, almost like 180. Okay, it takes a huge turn and then it fuses with the dorsal pancreas.
Thank you.
Okay, yeah. Let me see if there are any other videos for this one. Now, this is another video which is taken from your Langman. Okay, so it will show you the entire portion of the gastrointestinal tract. Okay, so you can see the ectoderm, endoderm, and the mesoderm. Okay, and what happens? Okay, the oropharyngeal membrane and the cloacal membrane, the yolk sac. Okay, now what happens due to the folding? You can see the foregut, midgut, and the hindgut. Okay, so the foregut, hindgut, and the midgut. The midgut is connected towards the yolk sac. Okay, now the midgut is getting narrowed with the yolk sac, and this forms the vitelline duct. Okay, the vitelline duct. Okay, and the hindgut and the other structure starts to develop. Okay, now here you can see this is the trilaminar layer. Now, because of the rotation, this is the mesoderm. Okay, now concentrate only on the endoderm. Okay, so now here you can see the duct. Okay, the midgut is getting initially connected, but if you see in the foregut, okay, so this part, it is separate. Okay, so now how does this occur? See here. Okay, so see here, if you get a connection, if you take a section, it appears that it is connected to the yolk sac. Okay, but here if you take a section, it appears that both are separate. Okay, it appears that they both are separate. Okay, all right. Okay, so now here you can see the dorsal mesentery, the gut tube. Okay, now we'll see the development of the foregut. Okay, so here you can see the respiratory diverticulum, stomach, the liver bud, the duodenum. Okay, now the stomach is showing the rotation of the stomach. So here you can see dorsal mesentery, ventral mesentery, and the liver. Okay, the right and left vagus. Okay, now because of the rotation, what happens? The left vagus, it becomes the anterior vagus, and the right vagus becomes the posterior vagus. Okay, because of the rotation of the stomach. Okay, the liver also expands. Okay, and from the dorsal mesentery, there will be the dorsal mesogastrium, there will be the formation of the spleen. Okay, and the pancreas. Okay, pancreas, you can see initially it is intraperitoneal, then later on it becomes retroperitoneal. Okay, now you can see the pancreas becoming a retroperitoneal structure, and the right vagus is going towards the posterior side, forming the posterior vagus, and here it is anterior vagus. This part is the lesser omentum. Okay, and this part is the falciform ligament. Okay, so this portion is the lesser sac or the omental bursa, and this is the greater sac. Now the same structures, if we are viewing it from the parasagittal view, So here, this is the epiploic foramen or the omental foramen and the lesser sac. So you can see the right margin grows at a lesser pace compared to the left margin, the lesser sac. Now the development of the liver and gallbladder. You can see the septum transversum, the developing liver. Okay, so now here you can see the ventral, the gallbladder, okay, the liver bud and the liver. Okay, this is the diaphragm. Okay, so that's the diaphragm, liver, gallbladder, dorsal pancreas. Okay. So because of the rotation, what happens? The ventral pancreatic bud comes along to the, get fused with the dorsal pancreatic bud. So liver, ventral pancreatic bud, dorsal pancreatic bud. Okay, so now the rotation takes place. You can see the common bile duct, cystic duct, gallbladder, common hepatic duct. Okay, now here in this picture, you can see how the duct fusion takes place. All right, now here you can see it, right? So now here you can see the dorsal pancreatic duct secretions are joined with the ventral pancreatic duct secretions, and this combine with the common bile duct, and then they open into the major duodenal papilla. Of course, they both are in the different levels, but in this animation, they are just showing it in the same level. Okay, they are at a different level. Okay, thereby forming the main pancreatic duct and accessory pancreatic duct. So here you can see the stomach and the duodenum. Okay, initially facing the posterior side towards the vertebral column. Because of the rotation, what happens? Okay, there is rotation of the stomach as well as the pancreas. So pancreas, which is initially intraperitoneal, then later on they develop from the, they become retroperitoneal structures. Okay, so that's it regarding today's session. Do you have any doubts?